Hi everyone, so really sorry I can't be there today. My CC was rescheduled. So I have created a VOP for everyone on spinal cord injuries. It's really important with spinal cord injuries to understand the functional anatomy of the spinal cord, and from there you should be able to reason your way through any injuries to the spinal cord. So I've just got a diagram up here with the brain and the spinal cord, as well as the paired spinal nerves coming off at each vertebral level. So you can see that the vertebrae and the spinal cord are divided according to, there are 4 different divisions. So we all know cervical, thoracic, lumbar, sacral, but then each spinal nerve again will have a different function, of different more specific functions. So for example, C1 to C4 is all about breathing and then head and neck movements and so on and so forth. So I've also got another diagram here that's a bit larger, a bit of a close-up of the spinal cord and its structure. So just a bit of anatomy revision. We still have the meninges here, and then the white matter and the grey matter, as well as your dorsal horn, and then the spinal nerves you can see coming out, the dorsal root and ventral root come together. It's important to understand that anatomy, but I'll leave it to you to revise in your own time. So here's a cross-section of the spinal cord. So I've just got on this diagram all the ascending tracts and the descending tracts and where they're located on the spinal cord, because in any partial spinal cord injury, it's really important to know where these tracts are and what the functions of each of these tracts are, so that you can work out what kind of deficit you'll have. So this should be revision. I know you've all talked about tracts a bit, but this is just a reminder because it does relate very closely to the types of spinal cord injuries that you can get. So this is another slightly less busy diagram of basically the same thing, but I just wanted to highlight these particular motor and sensory tracts, because not only is it important to understand where on the spinal cord they are, it's also important to understand where they decussate, so that you know whether the loss of function will be ipsilateral or contralateral. So I've written down on the diagram as well where they decussate, and therefore where the injury, where the functional deficit will be localized. So shock is another topic that people get a little bit confused about. There are 2 types of shock really. Neurogenic shock, which is like a classic type of shock that you would have talked about in your cardiovascular module, and then you have spinal shock, which isn't strictly a type of shock, but I'll talk about that in a second. So neurogenic shock is usually lesions above T1, and that kind of injury causes disruption of the sympathetic trunk. And when that happens, it leads to a loss of vascular tone and peripheral vasodilation, which leads to your sort of hypertension and your shock symptoms. And then when you have spinal shock, that's more like likened to a concussion of the spinal cord. So it's a transient disturbance really of the spinal cord function. And generally with the concussion, there won't be any pathologic changes. So in patients who have spinal shock, their symptoms will be flaccid paralysis and areflexia, as opposed to hypertension, which is what you get in neurogenic shock. So that's just an important distinction and something to remember. So autonomic dysreflexia is one of the topics that you should have covered in your CBL case, and that's a complication of a spinal cord lesion above T6. So it's important there to note that not everybody with a spinal cord lesion above T6 will get autonomic dysreflexia, but there are a number of triggers for that, which I'll talk about in 2 seconds. But basically what happens in autonomic dysreflexia is you have a loss of coordinated autonomic responses. So overall that leads to an exaggerated sympathetic response. So the symptoms that you're going to get are sort of headache, diaphoresis, hypertension. And although autonomic dysreflexia in itself is not life-threatening, if those symptoms, such as the extreme hypertension, persist, you can have long-term consequences, including like brain bleeds and other cardiac problems. So usually autonomic dysreflexia is triggered by some sort of GIT problem. So literally anything can do it. You can have like a bowel obstruction, you can have a UTI as well, or an infection somewhere. And basically the body's unable to control its autonomic response, and you'll get that exaggerated sympathetic response after you've experienced that trigger. But you covered that in your case, so some of you might know more about that than I do. So I just wanted to quickly mention a couple of important lesions to be aware of, because they can cause respiratory problems and respiratory distress. So a lesion at C1 or C2 leads to loss of the phrenic nerve, and a lesion at C6 causes loss of innervation to accessory muscles. So it's a bit of revision from when you studied the brachial plexus, but all of those nerves are important in respiration, and when you lose them, a patient may present with respiratory distress. So Brown-Séquard syndrome is one that comes up a lot for some reason, but essentially it's a hemidissection of the spinal cord. So in the diagram you can see here, if you have a hemidissection, this is kind of the area of the spinal cord that's affected, and what you'll get is ipsilateral muscle weakness, ipsilateral proprioception and vibration loss, and then contralateral pain and temperature sensation loss. So that's because both the dorsal column and the lateral corticospinal tract, they're on the ipsilateral side, but then the spinothalamic tract will cause problems on the contralateral side. So that's what I was talking about before, how it's important to know where those tracts decussate. So Brown-Séquard syndrome is usually caused by some sort of trauma or a compression by a tumour. Sometimes, rarely, you can get it as a consequence of infection, but those two are sort of the most common causes of that syndrome. Central cord syndrome is an acute cervical spinal cord injury, and the most common mechanism is hyperextension. So hyperextension of the cervical region of the spinal cord can lead to an area of focal damage that's sort of localized to the center of the spinal cord, as you can see in the cross section in the diagram, but it disproportionately affects the upper motor function. So you'll see a loss of motor function in the arms and the sort of the upper chest area, and then incomplete loss of motor function as you go down. That one is not something that normally happens in healthy individuals. Usually it happens in patients who've already got cervical spondylosis or something like that. That means that their spinal cord their vertebrae aren't entirely stable. So anterior spinal artery syndrome I think it's the last one that I'm going to talk about, but as you can see here in the diagram, this is the region that's damaged. So you can see here then that you lose all of your functions except for proprioception and fine touch, because the dorsal column is intact. So you will lose everything from the area of damage downwards, basically. So one of the common causes is severing of the Adamkiewicz artery. So that's one I think that has been brought up, should have been brought up in your cardiovascular anatomy at some point. Sometimes during surgery that artery can be severed. But basically it's an artery that arises from the posterior intercostal, and it supplies the anterior spine. And if there is a problem with that artery and you have insufficient blood flow, what it does, it affects the anterior spinal watershed region. So that region's at about T8. And for those who don't know what a watershed region is, it's basically a region of the body that receives dual blood supply from the distal branches of two large arteries. So in this case, there's the artery of Adamkiewicz and I think the anterior spinal artery that meet in that area. And so that area around T7, T8, T9 is the area that's most susceptible to to damage. So that's, I think, all that I wanted to say about that. And that's the end of my presentation. So a very short one, but I do recommend going over your spinal tracts and making sure that you understand those not only in the brain but all the way down to the spinal cord, and then even further into and then understanding the peripheral functions as well is super important. So thanks for listening. Again, sorry I couldn't be there, but I hope you enjoy the rest of your week.